Okay, welcome back. If anyone's in the hallway, maybe you can give a signal that we're starting again. My name is Paula Ravitz. I'm a psychiatrist, and I'm director of the Department of Psychiatry's Division of Psychotherapies, Health Humanities, and Education Scholarship, affectionately known as FES. And I'm head of psychotherapy for our Department of Psychiatry. And Jan Malad is here as well. He co-leads the psychotherapy stream with me. And I also am the Morgan Firestone Psychotherapy Chair at Mount Sinai Hospital, which is, I'm very grateful to both U of T and Mount Sinai Hospital. And we're at an exciting moment in the history of psychiatry and psychotherapy, learning about how when we change our minds, we can change our brains and alleviate symptoms and improve functioning, decrease suffering. And as well, we're at an exciting moment provincially and nationally as stigma around mental illness is lessened. You know, the Mental Health Commission's done such tremendous work along with World Health Organization in raising awareness about the importance of treating mental health. And at the same time, beginning to try to initiate, in many ways, improved access to treatment for mental illness, including psychological therapies that we know are effective. And many people are doing wonderful work locally and globally in that direction. And the provincial government is funding some online programs and peer support, along with the pilot of the increasing access to structured treatments that I know our guest speaker has been a consultant on and a very, very helpful and important in helping to shape that program. So it's my great pleasure to introduce Professor David M. Clark. He's a professor of experimental psychology at University of Oxford, well known for his pioneering work on understanding and psychological treatment of anxiety disorders, especially panic, social anxiety, health anxiety, along with PTSD. He has been cited thousands of times. I encourage you to look at some of his earlier clinical work. And more recently, he has also focused on disseminating effective psychological treatments within healthcare systems and is one of the architects of the English Improving Access to Psychological Therapies IAPT program. Currently, the IAPT program treats over 500,000 people with depression or anxiety disorders every year, reports clinical outcomes on almost everyone, which is nothing short of extraordinary. And 2 of every 3 people are reliably improved and 50% recover, so really good outcomes. He's also the UK government's clinical and informatics advisor for the program and a fellow of the British Academy, the UK Academies of Medical Sciences and Social Sciences, and the Association for Psychological Science in the United States. So please join me in welcoming Dr. Clark.
Thank you for that very kind introduction, and thank you for Benoit for inviting me here. And I'm going to largely focus on the issue of whether any of this matters. In other words, whether these psychological therapies can have a mass impact on the vast numbers of people with mental health problems. And the first sort of point to make is that the prospects for people with mental health problems, the in principle prospects for them, have really improved in the last few decades. And a lot of that progress has been to do with psychological treatments. We have a number of relatively new psychological treatments, often rather specialized forms of CBT, that have demonstrated effectiveness in clinical trials more recently. We also have a number of psychotherapies that have been around for quite some time, but also have much stronger evidence in clinical trials. In the UK, we have a body called the National Institute for Health and Clinical Excellence, or NICE, which is charged by the government to impartially review the evidence for the effectiveness of interventions throughout the whole of medicine, and then, if it thinks there's good evidence for something working, to make a recommendation that it's used in the health service, and occasionally, if it thinks there's good evidence that something is harmful, to make a recommendation that we stop using it. And starting in 2004, NICE started to issue clinical guidelines on the treatment of mental health conditions. And those guidelines indicate that certain psychological treatments are first choice interventions for depression, for all the anxiety-related disorders, including OCD and PTSD, also for the eating disorders and some personality disorders. Why do I say first choice interventions? Because these are all conditions where medication is also effective. And of course, NICE recommends medication as well. But it tends to give the edge to the psychological treatments because of the evidence that when you finish treatment, whether it's pharmacological or psychological, you have more enduring effects with the psychological treatments. So that's the good news, and this is the current NICE recommendations. So if we look at depression, we find that quite a number of different therapies are empirically supported. CBT and interpersonal psychotherapy across the full range of severities of depression, although in conjunction with antidepressants for the more severe cases. But also we have brief psychodynamic therapy, counseling, and couples therapy for depression as well. In the anxiety disorders, the recommendation is largely for cognitive behavior therapy, but not any old cognitive behavior therapy, but for rather specialized forms, which differ depending on which anxiety disorder you're looking at. And in PTSD, trauma-focused CBT, but also EMDR are supported. So that's good news. In psychotherapy, there's been a long debate, really rather linked to where I come from, Oxford. So Lewis Carroll, of course, had a nice story about the dodo bird, and there is an argument that all treatments are equally effective. There's also an argument that no, some treatments are more effective than the others. They're both right. It depends on the condition you look at. So in depression, I don't think we have very good evidence for differential effectiveness. We have quite a lot of things that are shown to be effective. In the anxiety disorders, I think for some of them we have really rather good evidence for differential effectiveness. So here's an example. This is the cognitive therapy for social anxiety disorder that our group developed, but it's been tested in trials in Sweden, Germany, as well as the UK. And it has been shown to be superior to another behavioral treatment, exposure therapy, to group cognitive behavior therapy, to interpersonal psychotherapy, to brief psychodynamic psychotherapy, and also to SSRIs and placebo medication. So pretty clear evidence of differential effectiveness, but in a restricted domain. And this gives you an idea of the power of psychological therapies. So this is data from our latest randomized controlled trial of different versions of cognitive therapy for social anxiety. And what we've got here is the distribution of patients' scores on the Leibovitz social anxiety scale at pre-treatment. The clinical cutoff is down here, between 30 and 40, so obviously everyone's in the clinical range, and they vary quite a lot in severity, but you see many of them are in the moderate to severe range. What I'd like to show you now is what happens to that whole cohort, it's 102 patients, when they've gone through a course of cognitive therapy and we follow them up a year later. Why am I showing you a year later? It's really not of interest to just get people better. You have to change their life, and that means you need an enduring effect. So you always need to look at follow-up data as well. And this is what happens to the distribution. So you can see it massively moves to the left. 75% of people are now in the non-clinical range. They're fully recovered. Most other people have shown some worthwhile benefit, but we don't have any psychotherapy that works for everyone. And you can see in this trial, we have 3 patients here who are very severe, and we didn't do anything useful for them at all. So we certainly need to keep on working on our therapies. But compared to some medical interventions, this is very impressive. So numbers needed to treat here are less than 2. Numbers needed to treat for statins are about 130. So these are very powerful interventions. So that's the good news. The bad news, in most countries, the public doesn't benefit from these advances. And it's not because they don't want to benefit from the advances. So there are now 32 public surveys of patient preference for psychological treatments or medication. And of course, quite a lot of people say, I would like medication, and they should get that. And often they do in most of our countries. but on a ratio of 3 to 1, there's a public preference for psychological treatments. And in no country anywhere in the world does the public get what it wants. There is no country where you have access to evidence-based psychological treatments at a higher rate than medication. And in the UK, until the program I'm about to describe started, we were in a really bad place. We only had 5% of people in the community with anxiety disorders or depression who were getting an evidence-based psychological treatment. Somewhat more people were getting some psychological treatment, but it was predominantly not evidence-based. So this really was an extraordinary inequality. And so the English Improving Access to Psychological Therapies, or IAPT program, has been an attempt to try and redress that inequality. And it aims to try and vastly increase the availability of NICE recommended psychological therapies for depression and anxiety. It took the point of view that one of the main reasons why people don't get these treatments is we simply don't have enough appropriately trained therapists. So in many ways, it's a mass training exercise where you're trying to train up a new cohort of therapists in evidence-based treatments, and also take some of our existing therapists and give them the opportunity to learn some of the latest techniques. And then we deploy them in specialized psychological therapy services for anxiety and depression. And obviously, this is quite a big public investment of funds. So we also aim to measure and publicly report the outcomes of everyone who is treated. So it is an extraordinary exercise in public transparency about mental health. The idea is that anyone, anywhere in the country, can look up what are the outcomes of their local service. And they can see, if I go to this service, what's my chance of recovering? In fact, you can all do that right now if you want. If you wanted to Google Common Mental Health Disorders Profiles tool, you could look at the outcomes of every single IAPT service in the country. So how did this initiative come about? Well, these sort of big social initiatives don't have a single route. They're quite complex in their development. The key starting point was having national clinical guidelines that weren't linked to any particular professional group. So NICE is independent of all our professional groups. And so it has a certain authority that our own associations don't necessarily have in the eyes of the public. So that was very important. Then it really was a partnership between clinical academics, such as myself, but also economists. And the critical economist here was Richard Layard, who you can see in the blue shirt there. He is a very distinguished economist, but he also has another very useful feature. He's a member of the House of Lords. So it gives us access to government in a way that maybe was difficult otherwise. So Richard and I put together an argument, a combined clinical and economic argument for making psychological treatments more effective, more widely available, saying not only will they help people, but they'll actually pay for themselves in terms of the savings they make. And that argument is outlined in this book here. It's the North American version, Thrive, How Better Mental Health Care Transforms Lives and Saves Money. And we've written it because we think people in other countries might also want to use the arguments with their own politicians. This is the North American version, so it has lots of figures in dollars and lots of American studies. There's a Dutch version, and that's in a very different currency and different stories. And then there was really a major lobbying campaign. We wrote a pamphlet called the Depression Report and had a benefactor who paid for it to be come out in every issue of the main national newspaper on a Sunday in the middle of the summer. And we also worked with patient groups to ask them, is this what they wanted? And they said yes. We showed them the Depression Report in advance, and then they wrote their own report, arguing for the same thing, but from a patient's perspective, called We Need to Talk. And we released the Depression Report on the Sunday, and then the voluntary sector groups released their report on the Thursday in order to control the media for a week, which we thought was critical. The Prime Minister at the time was Gordon Brown, Labour Prime Minister. He listened and made a commitment to start the programme. by the time Labour was voted out of office in 2010, the programme had collected enough data to show it was working, and so our more centrist coalition government agreed to expand it. And then our current Prime Minister, I'm not sure for how long, but our current Prime Minister, Theresa May, has agreed to expand it further. This is actually unusual, that you have an initiative that starts with, on the left of the political spectrum, is cherished and expanded as you move right away across the political spectrum. And I think the reason for this is it collects outcome data so you can see whether it's working or not. So what were the sort of arguments that were used to lobby for this program? Well, the first, of course, is to just help everyone understand that mental health problems are a very serious problem in terms of health. And this is World Health Organization data showing that 38% of all illnesses are to do with mental health problems. That really dwarfs heart disease, stroke, cancer, lung disease, diabetes combined, but it also is about as big as all the rest of the physical illnesses. But a really rather killer fact is this particular graph, and this looks at health-related disability as a function of age. And what you can see is that in the working age population, the big cause of disability is mental health. And so much so that the World Health Organization estimates that the gross domestic product of each of our Western countries is reduced by 4 percentage points as a consequence of untreated anxiety and depression. About half of that is to do with presenteeism, people who are anxious and depressed and are at work, but their mind is somewhere else, focusing on their worries. So they're less productive, the companies have to employ more people for the same output. But also, of course, when you get depressed, you often lose your job, and so we have absenteeism as well contributing to this. So the message here is, if as a society you want to have enough money in order to pay for the illnesses of old age, the cancer, the cardiovascular disease in your health service, you need to address mental health in the working age population, because otherwise your economy takes a big hit and you do not have the money. It's a straightforward economic argument. There's another argument which is rather important. Politicians are keen to be voted into power. And there are a number of studies looking at what are some of the big determinants of voting patterns, and one which is about to appear in science is one which shows that, in fact, one of the major determinants of how we all vote is our subjective sense of well-being at the time. So then the question is, well, what are the main determinants of that? This is a large European study looking at determinants of life satisfaction in the mid-30s. And what you have here is unique contributions of different factors, partial correlations. And you can see that if you have a higher income, then in general, you're more satisfied. If you are in a job, in general, you're more satisfied. If you've had more education, good for a room like this, you're more satisfied. If you're married or cohabiting, you're more satisfied. If you're not a criminal, it's good it's that way round, you're also more satisfied. And if we look at health, you obviously have to look at that sometime in the distant past, so it's not a tautological relationship, but if you look at it 8 years earlier, better physical health also influences your life satisfaction. But you see the big number, the one that's much bigger than all the rest, is mental health 8 years earlier. So another very good reason for societies to pay much more attention to treating mental health than we currently do. So those were many of the key arguments, but in a sense the clincher was to say, however difficult your economy is at the time, it's stupid not to do it from an economic point of view. And the reason for that is that it actually saves you more money than it costs. So when you're saying we don't have enough money, that's a sort of idiotic economic argument, because you want more money and doing it gives you more money. It generates bigger savings than the cost. This is Richard Layard's and my estimates that were originally published in the National Economic Review, which is a government publication. And we thought the cost of treating people with evidence-based treatments in a step care model would be round about 1,100 Canadian dollars. The savings in physical healthcare alone from that, because if you become less depressed, less anxious, you have reduced physical healthcare costs, would exceed that. But also the savings in terms of unemployment benefits, I think you call it employment insurance, is that right? Yeah, okay. And also when people get back into work, the increased tax revenues would also exceed that. What about these sort of healthcare savings? Where do they come from? Well, if you have someone who's depressed and also has diabetes, it costs 50% more to treat the diabetes than if they weren't depressed. And there are a lot of studies that show that if we treat the depression, we reduce the cost of treating the physical health problem. And in those studies that have looked at the cost of the treatment for the mental health problem and the savings, in 26 of the 28, the savings exceed the cost. So really quite compelling. In IAPT, we're creating new services, and I'll talk about that in a minute, which combine physical and mental health care in one place, integrated IAPT services. And we've been evaluating those, and we're finding really very large savings from that integration. So that was the argument. It was listened to by our government, and they agreed to start a national plan. The plan has been scaled up repeatedly by different administrations, and the current form of the plan takes us to 2024, but it started in 2008, and the plan is to train 16,000 new psychological therapists in NICE recommended treatments during that period, to ensure that what they deliver is a NICE recommended treatment. We create a national training curriculum, so everyone is trained to the same curricula. We have two groups in the workforce, what we call low-intensity workers, who do low-intensity treatments such as guided self-help, supporting people through computerized treatments and things, psychoeducation groups. And then if you don't respond to those interventions which have relatively low amounts of therapist time, that's why they're called low intensity, then the idea is you're stepped up to more conventional delivery of psychotherapy, once a week, regular sessions with what we call a high-intensity therapist. But both of them are trained to national curricula, which are strictly aligned to what was done in the randomized controlled trials that generated the particular NICE guidelines. So in CBT, we do not teach generic CBT. We teach the specific forms of CBT that were effective in PTSD and social anxiety, OCD, etc. And we've developed a national competency framework which specifies the clinical skills you need to acquire in order to deliver those therapies. And people only pass the training courses if they demonstrate those competencies in videotaped sessions of live therapy. And when the initiative was announced, the minister announced not only that it would treat a certain number of people, but he gave us an outcome target. He said that 50% of people should recover and many more should improve. I gave him that target based on a quick look at randomized controlled trials and thinking, if we train people really well, what was the best we could do? And I thought that would be about 50%. The senior civil servants told him, do not announce that figure, because it sounds as though it's going to be very tricky. And bless his heart, he got up in front of the nation and announced it. But then when we heard it, we thought, oh my God, this is going to be hard work. And as you'll see in a moment, it has been very hard work. But that was the plan. So where's it got to so far? So we're just over 10 years into the program. It's an ongoing program. It's far from finished. We've got a long way to go. But I think it is transforming the treatment of anxiety and depression in the UK. We now have these step care IAPT services in every area of the country. Our areas are called CCGs, or Clinical Commissioning Groups, and there are around 200 of them. We're currently seeing just over 1 million people a year in the services. And this shows you the sort of rate of growth of the services from the start. So obviously there's a limit to how many people you can train each year. And so there's a limit to how fast you can expand the workforce, and that's really determined access. And you can see in the first year we're only seeing 200,000 people, but we're now over 1 million. But of course, seeing people isn't of any interest unless they benefit from the treatment. So let's move on to that. So the first thing to say is not everyone ends up having a course of treatment. Quite a lot of people have an assessment, and it turns out that some simple advice is all that they need, and so they just have the one session and some advice. Some other people get referred into the service, but it actually turns out that it would be much more appropriate for them to be treated somewhere else, so they have schizophrenia or a very severe drug or alcohol problem, and so they're referred elsewhere. Or maybe actually debt counselling is really more appropriate for them. So it's about 560,000 people each year that we offer a course of treatment to, and those are the people that we're committed to try and getting outcome data on. So we say if someone has been seen at least twice, so there's a chance of observing a change because you have 2 data points, then the services must get the outcome data. And so that's the cohort that we look at. And we're now getting pre- and post-treatment measures of the severity of people's depression and anxiety on 99.4% of that 560,000 people every year. There was a national audit of psychological therapies before IAPT started, and we were getting outcome data on only 38% of people. So this is an extraordinary transformation. It's partly because we use session-by-session outcome measures, so that every time you're seen, you fill in a simple measure. So if you stop therapy earlier than your therapist anticipated, you still get a clinical endpoint. And Molin and I will be discussing the merits of this sort of system in our workshop after lunch. So what does the data tell us? Well, firstly, I should really persuade you that it's worth putting in effort in getting the data. Because a lot of people in England thought this is a bit obsessional, saying you have to get data with everyone. Does it really matter? Because actually it's sort of random whether someone gives you a questionnaire at the end of treatment. Maybe you forgot, or maybe they just didn't turn up that day. But we can safely assume that those people who don't give us data have improved as much as those who have. And that could be true, couldn't it? But it's an empirical question. You have to test it. And thankfully, IAPT has allowed us to do that, because with this session-by-session system, we get data on everyone. So early on, in one of our pilot projects, we decided to run 2 outcome monitoring systems in parallel. The session-by-session one, and then a conventional one, where we gave people a different measure of their symptoms just at the beginning of treatment and at the end of treatment. And with the conventional system, 50% of our patients had post-treatment data missing. But of course we knew what had happened to them because we had the session by session. And this shows you that it really does matter getting a complete data. So those people who on the conventional system don't give you post-treatment data have only improved 40% as much as those who do give you data. So our government concluded that we are simply deluding ourselves about how good our psychotherapy services are if we get missing data. So they said, if you want investment, you need to get the data. So that's been a keystone of the program ever since. So what actually happens in therapy, I said it's a step care model. It does vary quite a bit from service to service exactly how much low intensity and high intensity work is done. But broadly speaking, about 1/3 of people get low intensity treatment only and respond very well to that. But an almost equal number of people who start at low intensity then end up being stepped up to high intensity because they haven't fully recovered at low intensity. And there's some randomized controlled trials that show that that step up is important if you want to get a higher response rate. And then about 1/4 of people, the more severe people, go straight in to high intensity work. So it's not, for most people, it's not just a single intervention they get. They're often getting several different interventions in their course of treatment. And what you're going to see in outcome data is a consequence of that whole system of treatment. what are the treatments? Well, NICE recommends forms of CBT for all the anxiety-related disorders and depression. So that is the core intervention. But as you saw, NICE recommends quite a range of other treatments for depression. And we try and make them available in the services. And we certainly try and ensure that in each service there's some patient choice if you're depressed. You're not just offered CBT. And that's true at the moment in 93% of the services. And the most common alternative is counselling for depression. So most services will offer CBT and also counselling. But there are smaller numbers of people getting EMDR as well as CBT if they've got PTSD. Interpersonal psychotherapy, about half the services are also offering that. And couples therapy for depression is the next one. We're trying to make sure that's available in all services, and we'll be moving that forward in the next year or two. So there's patient choice. What are the outcomes? Well, the first thing is that this system has drastically changed waiting times. So before IAPT, it was pretty common for people to have to wait up to a year for a course of psychological treatment by a fully trained therapist. But now the average waiting time is just 20 days. So a very big drop. Okay. And if we look at the outcomes, then we're really on target for what we'd predicted now, although you can see it took us a while to get there. So roughly 7 in every 10 people who have a course of treatment, so I've seen at least twice, show what we call reliable improvement, substantial, statistically reliable reductions in their anxiety, depression, and disability scores. And 5 out of 10, that's 52% at the moment, are rather arbitrarily coded as recovered. So they've dropped below the clinical threshold for both anxiety and depression. It's not like a drug trial where you say someone's recovered if they drop below the depression threshold only. We're treating people, not syndromes, so we need them to be, in general, well. So we want both to come down. But of course, what happens whenever you start collecting health data of any form, outcomes of cardiac surgery, survival rates for cancer, and in this case, in mental health, you find that when you collect the data, you see variability. Some services do a lot better than others. And that's gold dust. That's the magic which allows you to study what are the big determinants of these things and learn from it. So that's been a big part of the IAPT program, and it has really helped us. So this shows you that government target, the recovery rate. So the red line is the 50% recovery. And you can see when we started the program, we weren't that close to it. We're about 40% recovery. And it has taken us 8 years to get to this 50% target. So you could see the senior civil servants who said to the minister, don't announce it. There was some logic perhaps in it. But the fact that it was announced meant that we knew we had to strive for it. And it's really been an enormous amount of learning about how to deliver these therapies at scale, which has allowed us to get to this point where we're now exceeding the 50% target. We've exceeded it every month for the last 24 months. We have some services that are operating at 65% recovery for the whole sort of age group. I should say, by the way, that if you're over 65, then IAPT is really good for you. The national recovery rate is 65% for older people. We do better with older people than we do with working age population, but we don't have so many of them. So the working age population, it's 50% recovery. So we will push on, and we're pretty confident we're going to get to over 60% by the time we've finished, because we know we've got some services that are doing it every month. What's the sort of variability that we have, and how's it being used? So here it is. So 68% is the sort of reliable improvement rate, but you see the range is from one service is 33%. Thankfully, it's only one of them, and some that are even up at the 80s. And the same range you see for recovery. Of course, psychotherapy can do harm as well as good. So we also measure what we call reliable deterioration. Is someone more severe in their symptoms at the end of treatment than at the beginning? And we publish that for every service. We're not worried about it. The average rate is 6%. If you were on a waiting list for these sort of problems, it would be about 25%. So we don't think they're harmful. But it's the canary in the mind. It's a way of trying to spot these things. And we look at individual therapies and individual services as well. PTSD is a sort of one you have to look at closely. But of course, what we're trying to do is spot those services that are struggling and not doing so well, and then feed back the sort of learning that we've got to help them improve. And this really illustrates that process. So this is the number of CCGs that were above 50%, I'll do it this way, at 4 years ago, and it was 84 out of 200. But you can see we've now moved up to 160 out of that 200. And if we look at the value that we were at the start of the program, 40% recovery, then 4 years ago, we had almost a quarter of our services at below 40% recovery. But today, we only have 4. That's 2%. So we've managed to pick off the low performers and really move them up. So this is a really good example, I think, of sort of data-driven or evidence-driven service innovation and improvement. So what are some of the lessons that we've learned from this variability? Well, one of the early lessons is that clinical guidelines matter. This is quite a controversy in the field, and this very large program allows you to look at this naturalistically, because we do have some therapists who like to ski off-piste when they're on the holiday, and when they come back from the holiday, they quite like to do the same, and maybe just do some different therapy from what the guideline says. And that's a natural experiment. We can see, does it matter? And whenever we've looked at it, it does matter. So in depression, NICE recommends CBT, but also counselling. And we find they get equivalent outcomes. But in generalized anxiety disorder, NICE does not recommend counselling. It just recommends CBT. But many of my counselling friends say, but we do really well with generalized anxiety disorder. We've got lots of people getting better. And the answer is they're right. Lots of people do get better with counselling. But the rate is 46% in our sample, whereas it's 58% with CBT. So, of course they're right, but what they didn't know is if they were doing CBT, it would be true for even more people that they see. The same happens at the sort of lower intensity end. So we're really using guided self-help. You have a therapist who contacts you every week and guides you through the self-help programs. That's what NICE recommends. And we find that that gets much better outcomes than just giving someone a booklet or just access to a program. We also find that if you have a step care system, it's important to use it. So those services which have a higher step-up rate, if you don't fully recover, they step you up promptly, get better overall outcomes. More recently, we've used all the publicly available data. You could do these analyses. You can download all of this data, service-level data from our websites. I get my undergraduates to do it in a class, just to see how good their stats are. And this is an analysis that we published in Lancet last year, where we looked at predictors of variability in outcome between different IAPT services. And these are all unique predictors. It's a multivariate model. So the first thing, and very relevant to me as a psychologist, is in my profession in the UK, and I think it might be true in Canada, I'm not sure, there's a controversy about whether diagnosis is an appropriate thing. And some psychologists think it's really helpful to get a diagnosis. Other people think it's really evil. And we have that variation in the UK. And partly because of this, we don't call it a diagnosis, we call it a problem descriptor. We say, we'd like you to identify, what is the main problem that you're tackling? Is it PTSD? Is it social anxiety? Is it depression? So our problem descriptors are not formal psychiatric diagnosis, but they are aligned to DSM and ICD. Okay? And what we find that in some services, they rarely identify the problem descriptors. In other services, they did it in everyone. And it turns out it really matters. So those services that are very good at spotting the problem descriptors get much better overall outcomes. And that's presumably because NICE guidance differs with problem descriptors, so you've got a better chance of having the right evidence-based treatment. There's also, just like with medication, there's a dose-response effect. Those services that give a higher average number of sessions get overall better results. But the optimal average is not very high. If you look at the regression curves, 9 sessions is the optimal value to get the best outcomes. Of course, that doesn't mean to say that people are limited to 9 sessions. Many people will get up to 20 sessions, which is what NICE would recommend. But of course, some people respond with many less. And so that's how you get that average. How long you wait for treatment to start turns out to be very important. And this is shown on this graph here. So what we've plotted here on the left-hand plot is the blue dots are an IAPT service, and it's data for a full year. So each blue dot represents about 7,000 patients. And what we've plotted is the probability of people in that service improving when they have their course of treatment as a function of the average weight that people in that service have before they start treatment. And you can see there's a window of opportunity. It doesn't really matter how long you wait for the first 6 weeks. But after 6 weeks, if you end up getting what appears to be a similar treatment from similarly well-trained therapists, your chance of recovering drops substantially. It's a big deal for many people coming forward for psychological therapies. You know you have to talk about some painful, difficult issues. And when people are referred, they're often willing to do that work. But as professionals, we can't rely on that window always being open for us. And we think this window is starting to close after a while if we don't respond. This graph has changed government policy. So we now have a national government target for people being seen within 6 weeks in IAPT services. That's all sort of regressions that you're seeing, and all of you know correlation doesn't demonstrate causation. So one way of getting a bit more at it, when you can't randomize people, is to also look at change across time. So for today's meeting, I also looked not at just the data set that we used in the Lancet paper, which was from 2015, but essentially the data for 3 years later, 2018. And I've looked firstly at, have we got better at those variables? And we should do. I've been doing workshops throughout the country for a few years on these points. And yes, we have. So you can see IAPT services are much better at identifying problem descriptors now. We're up to sort of 86%, where we were at 68%. Our average number of sessions has gone up, and the average wait time has gone down. What we call DNA rates, people not attending a session, but you're not advising the therapist, which is another predictor, has gone down. Those are all significant changes, but does the extent to which your service improves in those variables predict the extent to which it's improved in its outcomes? And the answer is yes. So if you look at the R squared, almost 40% of the variability in outcomes across time is determined by improvements in those organizational factors. To me, this is extraordinary. I spent almost all my life working on trying psychological models and testing psychological models, a bit of neuroscience, trying to develop new treatments. And that's all just about how good the treatment is. But what this shows is there's another variable that we've really completely ignored in mass implementation, which is the organizational system that you deliver them in. And that seems to be actually as potent as the difference between an active treatment and a placebo. One variable that I didn't mention before, but those of you who are eagle-eyed would have noticed it was on the Lancet slide, was social deprivation. So obviously some areas of the country are much more socially deprived than others. And what we find, if you look at a sort of simple univariate relationship, is that if you live in a more socially deprived area, then the overall outcomes of your IAPT service are less good. However, when you take into account most of the sort of quality criteria that we saw, average number of sessions, problem descriptors and things, we find in the regressions that the effect of social deprivation is greatly reduced, which suggests that what's happening here is that if you live in a socially deprived area, you tend to also be deprived of a top quality mental health service, and that we could maybe finesse the effects of social deprivation if we make sure you get a good quality IAPT service. That's what the overall data shows, but I thought I'd give you a cutesy little illustration of this as well. So some of you might have been reading about Prince Harry and Meghan, and the fact that they've just moved into a new house in the Windsor estate for the new baby arriving. Windsor is one of the least socially deprived areas of the country. It's on the 4th percentile in terms of social deprivation. However, it is next to an area which is one of the most socially deprived in the south of England, which is an area called Slough. It's at the 68th percentile. However, both of those areas are served by one very high-quality IAPT service. And you can see that as a consequence of that, if you live in Windsor, you get a recovery rate which is higher than the national average, 56%. In Slough, it's slightly higher still, and the same is true of reliable improvement. So if for any reason the Queen felt that she would like to access an IAPT service, we might suggest that she gets the chauffeur to drive her to Slough, if anything. So we can finesse the effects of social deprivation, but we've just got to get our delivery right. So a lot of the lessons that we've learned from this program, and it has been a big learning exercise for us all, are in a document, the Improving Access to Psychological Therapies manual, the IAPT manual. You can download that from the NHS England website if you're interested in all these features. I don't have time to take you through all 12 chapters which show you many of the other things that we've spotted. But it's been a big learning exercise for us all. Where are we going in the future? Well, successive governments have been very happy with this initiative. They felt that it has really demonstrated that it is worth investing in mental health because people can get better. And as a consequence of this, we've recently announced what we call the long-term plan for the National Health Service, and a component of that is a government commitment to essentially double the size of IAPT by 2024. So we're currently seeing 1 million people a year, but the commitment is to make it 1.92 million by 2024. But of course, we don't just want to expand it, we also want to improve it. And there are two areas where we're trying to improve things. The first is for those people who not only are depressed and anxious, but also have a long-term physical health problem, like cardiovascular disease, diabetes, chronic obstructive pulmonary disease. Those people are doubly handicapped. But our health service doesn't do a good job with them. The best that can happen is they get appointments to deal with their chronic obstructive pulmonary disease or their diabetes in a hospital over there or a clinic over there, and then they get appointments for their mental health problems in somewhere over there. And if they manage to go to those different appointments, the one thing you can absolutely guarantee is that the person who's treating their physical health won't talk to the person treating their mental health. This is a strange, weird Cartesian dualism that makes no sense when you're treating individuals. So we have a moment in history where we're trying to break that system. We're trying to pull together our physical healthcare and our mental healthcare by putting some of our IAPT therapists in cardiac rehab units, in diabetes clinics and things, so that we bring together the physical healthcare and the mental healthcare. And that, of course, isn't just because that's the right thing to do, but it's also because the economics scream that direction. And you can see this here. So we're at an early stage, but we've gone through 2 waves of developing these services in some areas, and they are increasing access to treatment for people with long-term physical health problems, and we are seeing quite big reductions in physical healthcare costs. So in the area where I work in Oxford, where we use the sort of stepped wedge model, we introduced the services in some areas earlier than others, so we had a control condition. And we find if you just look at the 3 months that people are in treatment, you find that you have a saving for going through the IAPT treatment if you have a long-term physical health problem as well, of £345. That's about double it for dollars, is that right? Yeah, okay. With Brexit, it won't be such a big increase. And that's just in that period. But of course, these are sustained effects. So we're pretty confident we're covering the cost of treatment by doing this. What's the other future development? Well, you heard from Faith's lovely talk that digital is a big player in terms of mental health now. It's the biggest area of psychotherapy research. There are, in fact, more than 230 randomized controlled trials of internet-based treatments just for depression and anxiety at the moment. And there are different ways in which you can use digital things to improve delivery of therapy. The simplest way, of course, is just remote delivery of normal therapy by video links and things. And if people live a long way away, that can be a really big help. And for students who maybe are in the university during term time and somewhere else in the holiday, you can get continuity of care with this way. So that's a big part of the development. But of course, the biggest part is internet-delivered therapies, because psychological therapies are a learning exercise. You're learning new skills to deal with emotional problems. And a lot of that learning could be done on the internet, just as any other learning could. And this is, of course, a big area of research. The RCTs show that certainly internet-based forms of cognitive therapy are very comfortably superior to no treatment. They also show that on average the best outcomes are achieved if you have a therapist who's supporting you through the treatment, which fits IAPT very well because we've got a new trained workforce. What the therapists do varies quite a lot with the program. Sometimes it's just simple coaching, sometimes it's much more expert input depending on the program. There are 20 randomized control trials that have compared face-to-face therapy with internet guided therapy, so assisted by a therapist, and those trials find no significant differences between the two. But I think it's fair to say that none of them are properly powered as equivalent studies. They're just really no difference ones. So a bit more work's required there. And I don't think any of them have compared the internet treatment against what we would say is the absolute gold standard treatment for that condition. So there aren't any trials where the face-to-face therapy was done by the teams that developed the face-to-face therapy, and there were competence ratings of how well it was done. But, you know, it's certainly doing good stuff. It may have been slightly overhyped about how good, but it's useful. And, of course, it's potentially saving therapists time. So we're bringing these treatments much more into IAPT. This is a sort of front page of one of ours. This is an internet social anxiety treatment. We take everything in our social anxiety treatment and we put it into the internet. Video feedback is a key component of our treatment. You have conversations with other people, we video them, you get to predict how you think you look, and then you compare that with how you really look. Well, that's part of the internet program. So there's a secure video link in it. You can have conversations with someone else. It videos both ends of the conversation and plays it back after you've made your predictions. You get a chance to talk to lots of virtual audiences who vary from fairly simple, small audiences who smile at you to audiences of several hundred who seem to be bored looking at their mobile phones and things. That never happens in meetings, of course. Of course, the big advantage of these internet treatments is potential saving in therapists' time and also more convenient access for people. You don't have to travel to the clinic so much. But it also is a moment of, I think, we're on the cusp of a real breakthrough in psychotherapy research. I wish I didn't have grey hair. I wish I was starting my career because I think it's so exciting. For all of my lifetime, psychotherapy research has been a messy business. It's been a messy business because psychotherapies are, even with the best therapists, inconsistently delivered. You have a good day and a bad day. You don't always deliver the optimal content. Also, the sample sizes in our trials are very small. And if you get some of these treatments, like the social anxiety one, where you're getting sort of 75% of people fully recovered, then you don't get that many people who don't respond. And that's a problem, because you can't really study what it is about them that is what you haven't managed to change. So the wonder of the internet treatments is that it's very consistent in what it delivers. So you've got much tighter control over the intervention. But also the sample sizes can be vast. So you can do trials, and people are moving towards this now, where you could get thousands of people, tens of thousands of people, and then you can reliably identify what are the moderators of change. So if you're interested in cognitive therapy, what's the particular intersection of particular beliefs and behaviors that we can't unlock with our current treatments? And then we can bring people with those problems into the lab, and we're usually quite good at finding out how to unlock them once we've got them in the lab. And then we can change the content of the online treatment and randomize people to the old treatment and the new one online. So I think our understanding of psychotherapeutic techniques is really going to advance at a much greater rate as a consequence of the internet treatments. But there is another digital development which I thought I'd just finish with because it's a really interesting one, which is, of course, virtual reality. And this is particularly relevant, I think, when fear is the main thing that you're treating. Obviously, everyone knows that a key component of all therapies for anxiety, including psychoanalytic work, Freud was very clear on this point, is exposure to feared situations. But of course, for some people who've got certain phobias like flying phobias or height phobias or phobias of spiders in the wrong season of the year, it's difficult to get the relevant stimuli into the therapy office. But of course, with a virtual display, you can always do that. Also, there are some people whose fears are so extreme they won't do real-life exposure. Take people with paranoid psychosis who think that actually if they go into a shopping mall, someone's going to kill them. They're not going to go into a shopping mall with a nice therapist. But you can, of course, give them that experience virtually. And so we, and particularly in Oxford, Daniel Freeman, another clinical psychologist, have been developing virtual reality versions of treatment. And I'd like to show you an example of that. So this is Daniel's treatment of height phobia. And so what you'll see is a patient who one of the things he couldn't do is he couldn't go to the new super-duper shopping centre in Oxford, which has lots of walkways at different levels, and all of them have glass screens at the side, so you can sort of see down. And his friends wanted him to go around this shopping centre, and he couldn't. There were lots of other things he couldn't do in life. So you see him being taken into the shopping centre and really not managing to look over the edge and things. And then you see a little bit of what he had with his virtual reality treatment. It was 6 sessions of 30 minutes each, 2 sessions a week. So short treatment, just 3 weeks. And then you see him going over the same environment after treatment. So you see he's staying very far away from the edge. Very bravely getting close to the edge, but holding on to the concrete pillar. And that's about it. Here he is now having his virtual reality treatment.
This would have been simply impossible 3 months ago. It would have been total avoidance. I wouldn't even have attempted this.
So you see, it's really a remarkable transformation. Quite brief therapy, but allowing virtual reality to get you all the key ingredients that we know are important for this type of therapy approach. And we've been doing the same with people with paranoid psychosis. And we've found that we can get people who are not leaving their home because they're worried about being attacked to then leave their home, go around crowded shopping malls, go on public transport. When I started it, I think Faith was telling you a lot about being skeptical about certain things until you tried it. Well, I was sort of giving Daniel Freeman advice about how you could sort of do the psychological therapy maneuvers in the virtual environment, and I thought, I'm sure we can get people to be less frightened in the virtual world, but I said, I'm sure it's not going to transfer to the real world. Well, the point about science is you can show yourself to be wrong, and boy, was I wrong, but Daniel always believed in it. So that's a sort of quick overview of the IAPT program in England, saying a little bit about how it's going elsewhere in the world or what the interest. So Nature had an editorial describing it as a world-beating program. The New York Times had a good feature-length article recently describing it as the world's most ambitious attempt to treat depression, anxiety, and other common mental health problems. It is starting to be copied in other countries. Norway is the most advanced, so they started their IAPT program in 2012. I went and announced it with the Norwegian health minister and the team. They now have 40 different IAPT services, and they're getting outcomes very similar to the ones in UK. Sweden has quite a lot of Stockholm now devoted to an IAPT service and is doing very well. Israel recently announced a national pilot of IAPT. Australia has quite a few IAPT services, and Los Angeles has now developed an IAPT service in a particularly deprived area of the city. Kamesh has commented on it. So David here wrote an opinion piece in the Globe and Mail and said, rather provocatively, for better mental health care in Canada, look to Britain. Paul Kurdiak from Kamesh also, we're working together a bit on the outcome monitoring, and he kindly pointed out that you shouldn't just take anything that an Englishman takes as sense, and that you have to think of your own program. And just to emphasize this, when he bought me a drink, he made a point of buying me pompous ass English ale. So, you won't want to just copy this, but I hope some of the ideas will be of interest for you as you develop your own services. And I've learnt an enormous amount from doing this. When I started my career, I thought if I worked really hard and with a good team, and we have a wonderful team, getting the experiments right and the theories right, and designing the interventions based on them, we could get more effective treatments. And then we'd publish them, we'd do an RCT, we'd publish them in a prestigious journal, and then we could rest, go on holiday, and the health services would implement these treatments. That was really the idiocy of youth. I realized it just doesn't happen like that. And it doesn't happen like this because, all the research is funded by research councils and charities, and they don't have that much money. They can't spend the money on implementation. And it's not a commercial product, so there's not a vast amount of money coming in to then get it into health services. So unfortunately, we as clinical academics need to do that work as well, which is why I have got grey hair. I think some of the things I've learned in that process are, firstly, it really does help to have national guidelines or adopt some guidelines. And it really is incredibly important to get outcome data on everyone. If you don't, we don't know really how things are going. If we hadn't got outcome data on everyone in IAPT, we would still be getting 40% recovery where we started from, because they were all well-trained therapists that we had at the start, and we would have been blissfully ignorant of the fact that we're only getting 40% recovery. So we as professionals would be doing fine. The only problem was there'd be 100,000 people in England who weren't recovering as a consequence of our ignorance. So getting the data really matters. The other thing that we found matter is the economics matter. Most governments are driven by the Treasury, and you really need to make the economic argument for expanding mental health services. It simply doesn't work to just say these treatments work, we should have them more available. It really is the dollar which is a critical bit of it. So for me, it's always important to make friends in life, but I've discovered that for this exercise, there are two types of friends that are more valuable than anything else. One is economists, and the other actually is politicians, who turn out to all, in my experience, be very interesting, very dedicated people, if you give them a chance. But of course, psychological therapies are difficult to deliver. It's not like medication. Unless you've got a corrupt drug company, that particular tablet has the same amount of active ingredient in every tablet. But a psychological therapy, if it's not delivered by someone who is well-trained and closely and regularly supervised and also gets their outcome data, then the outcomes are likely to be what you get from a placebo, not the specific effect. And then, of course, the whole economic argument falls apart. In order to ensure you get the data, we found that you need an IT system that supports it, one which is helpful to the clinician. So it allows the clinician and their patient to see graphs of progress in every therapy session. It allows you in supervision for your supervisor and you to look at the graphs of progress in all the different measures in supervision. And it isn't a burden to you. So the data input can be on people's mobile phones and things like that. So you're not wasting valuable therapy time with people filling in questionnaires and things. And that becomes an automated system. And of course, whenever you measure things, measurement is sort of neutral, but it can be made into something wonderful or something dreadful. So you can, of course, if you have services where you've got targets on recovery, it can be a horrible place to work, because you might have a manager who says, well, we're not meeting our 50% target, and everyone feels blamed for it and doesn't stay in the service long. And that's clearly not what you want. You need clinical leadership, which is inspirational, where people use the data to learn new things, and who are really interested in those people who don't respond, because they're the most interesting people that you have. They're the ones that we can all learn from. So you need clinical leaders that organize services so that everyone in the service can do what they got into the profession to do, which is help as many people as possible by learning. And so we focus quite a lot of work now on getting the clinical leadership in these services right, and also on staff well-being. Because, of course, if your staff are feeling oppressed as they go through treatment, then you're not going to get consistently good results. So it's very important to look after your staff in order to get the best results with your patients. So thank you very much for listening.
So we will open the floor for questions. Dr. Masson.
Wow. So, David, I want to continue on the discussion we have had, and I alluded in my comments. So, two issues. We love your step 1, step 2, but in your model, where is step 3, where is step 4 for the sicker, the complex trauma patient who need more and may need even longer term therapy? And the related question, can you tell us what did you're at Oxford in the Department of Psychiatry, you work with psychiatrists, they are not part of your model. What did your colleague do wrong we can avoid here so that we work with the psychologist and the occupational therapist and the social worker to be part of the Canada IAPT people in the room? No, I think we should be responsible for the step 3 and 4 when, for instance, psychologists say, I don't want to take care of those patients, they are too complex. But what can we do differently? What was done wrong? And what happened in your current system for those people?
Yeah, so these are all very good questions. So, I mean, the first thing to say is that IAPT is often described as for mild to moderate symptoms, and that is not correct. So if you look at the national data, you find that on the PHQ, the mean score for depressed people at the start of treatment is nearly 18, and the cutoff between mild to moderate and moderate to severe is 17. So we've got slightly more than half the people in the moderate to severe. So it is taking quite a lot of severe people. But what it's not taking is people with a very marked immediate suicide risk, and they tend to be dealt with in the psychiatric services. It is also not taking those people who you think you need a multidisciplinary team to work with, who again would be in our more conventional psychiatric system. So those are the other steps, and they exist, and people go into them. But of course, it would be nice if that was joined up more, wouldn't it? So, and one of the interesting things about IAPT is that when we started, it was really radical. The idea that you get therapists to measure outcomes on everyone, and you would publish that data, members of the public could see outcomes, was something was very challenging. And many members of my own profession didn't want to do it. And also there were a lot of issues about, do we really want to do evidence-based treatment? And so we felt, because that was so radical, it didn't make sense to just try and transform our existing services. There'd be lots of people who didn't want to do that. And why should we force them? So instead what we said is, well, mental health problems are vastly undertreated. We need to increase capacity. So this is on top of our existing services. It's not instead of them. And, but if you want to join it, opt into the revolution. But if you do opt in, and you get a new job, but you are committed to the outcome monitoring, you are committed to the evidence base. And I think, in retrospect, that was really critical, because it allowed us to create services with people who really wanted to work this way, and of course it meant they got very good outcomes. But of course, now, down the line, we've created a system which is somewhat separate from the rest of our healthcare system, and now we're moving to integrate it more. And I talked about the integration with physical health, which is working well, but we're also trying to integrate it with the rest of our psychiatric system as well. One of the impediments to that at the moment is that outside of IAPT, we don't have universal outcome monitoring. So what we need to move towards is that when we're also treating other depressed patients who are more complex, where we're really needing many of the skills of psychiatrists who are very good at some of the longer-term therapies, but also extremely good at this pharmacotherapy in a way that our family doctors aren't, we need the patients still to stay in the same continuous IT system and get their outcomes monitored the same way. So we can learn from that, because, of course, it's one thing to say, we'll make this formal arrangement, you know, if you meet certain criteria, we'll move you on to expert management by a psychiatrist, as well as, you know, the CBT, and adjusting the medication in the clever way that I know you would do, for example, and many other people here would do. But, you know, that's a sort of concept. You need to collect the data to see whether your idea is right and whether you want to refine it. So I think the big change that we need to make is to get universal outcome monitoring. And so, in fact, on Monday, we have a call among the different medical directors in the NHS about planning how we can put outcome monitoring into every aspect of psychiatric provision in the UK. So, of course, the outcomes may be different. So we are developing new services for homeless people and psychiatric services. But we're saying, you know, there's some new money there. We need to specify what we think would be a good outcome, what we think we could achieve, and then agree on a measure for it and measure it and report it. Because in all of these systems, whatever they are, you get variability. And that's a tragedy if you don't measure it, understand it, and change it. But if you do measure it, it's, you know, it's magic, because you can really move things forward. We have had some psychiatric involvement in IAPT so far. The service that showed that outcome measurement was very important, that showed that if you didn't get complete data, then you were misleading yourself, is actually run by a very distinguished psychiatrist. So we have had some, but it's a modest input at the moment. For the more severe patients in whom we want to combine medication and psychological treatment, of course it would be ideal to have much more expert input into that. And so that's one of the developments. In the UK, we have quite a lot of psychiatrists that are also quite interested in developing skills in these briefer psychotherapies. Of course, Isaac Marks was a very distinguished figure in the field, and there are many people who've been his disciples who've developed that. And some of the treatments that we're using in IAPT at the moment, like the CBT for body dysmorphic disorder, was developed by David Veal, a very well-known psychiatrist. So there are lots of openings. Is that a useful answer?
Hi, Professor Clark. Thank you for a very inspiring talk. I think the whole IAPT initiative has been so inspiring. My name is Peggy Richter. I had a program devoted to OCD.
Yes.
And amongst other things, we've been trying to develop a variety of educational initiatives, training initiatives to build capacity, because OCD has been shown to have one of the largest treatment gaps of all mental health conditions, if not the largest. So I was really interested when you showed your outcome data, and I'm sure you have this, but I'm just wondering if you could comment on whether you see differences
OCD
across
gets one of the
disorders.
best response rates.
And so response rates, but also in terms of how you approach training, and whether you've rolled out training as universally for things like OCD and PTSD, where arguably that gap in knowledge is even larger.
Yeah, so the national curriculum covers all of the different sort of anxiety-related disorders and depression. So people going through it do get trained in treating OCD. It's particularly they're trained in exposure and response prevention with some cognitive add-ons as well, but the core is exposure and response prevention, because that's what NICE recommends. And in PTSD, we teach people in trauma-focused cognitive behavior therapy. It's a predominant modality, but some people are also trained in EMDR. In terms of the outcomes, OCD is one of the conditions where we get actually some of the best outcomes, but we also, when you look at the data, have the highest number of sessions. So, you know, it is a difficult condition to treat, and you can't skimp on the treatment. But if you don't skimp on the treatment, we do well. PTSD, we still have a bit of a way to go, and we think the problem is that in our training courses, often therapists don't get much chance to treat someone with PTSD while they're on the course. And I think it has a particular challenge, doesn't it, that when you're activating these memories in therapy, of course, people get very distressed, and most of our therapists focus much more on reducing distress, so they find that a bit more difficult to manage. And I think it's really critical that you have some closely supervised PTSD cases during your training. So we've just issued a revision of our national training curriculum, which actually requires people, as they go through training, to have at least 2 closely supervised PTSD cases before they can complete their training, which I think is important.
We have a question from some of our virtual participants. This is from Dr. Daniel McBain, and he asked if you could please provide the URL for the social anxiety website that you displayed on the screen, and that you mentioned the site features simulated audiences.
Yeah,
and,
well, so there's a website called OXCADAT Resources, so OXCADAT resources.com, and that has an enormous amount of detail of our social anxiety treatment and also of our PTSD treatment and our panic treatment. So, for example, for the social anxiety treatment, you can see a full-day workshop with me showing how to do the treatment, and there are about 40 short video clips illustrating the key techniques. And this is a free therapist resource. Anyone can log on, register, and watch them. And we have the same for PTSD. The particular internet program we haven't made widely available yet. What we've done is we've done a randomized control trial where we compared it with face-to-face therapy, and it did as well as face-to-face therapy. We've then done the same in China, because we thought, you know, the internet will keep on delivering the product. Wouldn't it be cool if we can treat Chinese people just as well, if they understand English, because we didn't translate it initially. The outcomes in Hong Kong with the Chinese population are as good as they are in London with an English population. It's really interesting. And we're doing the same in Japan. And when we've finished that sort of work, we're then working on how to train therapists to support patients effectively in the treatment. And so we're developing online training for therapists to then be the therapists for the online program. And when we finish that work, that's when we'll make it more widely available. At the moment, we're making it available in a phased way within IAPT services, where we've made it available in 10 IAPT services, and we're studying how best to train the therapists. Because it turns out that how you train the therapist is also important, just like in face-to-face therapy. I hope that answers the question.
Thank you very much for the wonderful presentation. Lila Amirali, child psychiatrist from Montreal, Quebec, and very involved in the deployment right now of the NICE guidelines for exactly this program for children and adolescents in the depression guidelines that we're using. And I have a couple of questions about the implementation, actually. How do you engage people who work, therapists, either psychotherapists, psychologists, and other therapists, as well as psychiatrists from academic environments who have been practicing a particular type of psychotherapy, but is not particularly part of the NICE guidelines? How do you engage them to participate in a program like that?
Yeah.
Do you have any pointers? And my second question, what were some of the biggest challenges in this type of deployment when you try to put together a plan that includes all psychotherapists as well as sort of more specialized areas? How do you bring the two factors together when you start from scratch?
Yeah, okay, so we don't, is the answer. In terms of, you know, how do you manage people who have very different orientations initially? I think we only really work with people who want to change, as they say in psychotherapy. So if you come from a different orientation and you're really interested in learning this, then of course you're a great asset to IAPT and you'll come on the training courses. But we're not trying to change all of our existing services, at least in the adult program. What we've said is, you know, most people don't get treatment, so we can have some added capacity. We don't want to change everyone. And I think that was critical. We have a children's program, which started later, which was more of a service transformation program. So it did have exactly this issue. And it did some really wonderful work in training people up, but one of the issues with it was that it was much less successful at getting outcome data. So after about 8 years, only 30% of patients were getting pre- and post-treatment measures, whereas in the adult program, after 9 months, 92% were getting it. So I think that's partly to do with, whether you've got people who are, who are really interested in it. So that's why I use the sort of term opt into the revolution rather than force people. And then, we're not, I think a lot of what already goes on in different psychotherapy services is very valuable. We're not really wanting to replace that. It's an addition. And I think that's a critical way of thinking. I think, if you say, well, there's some extra money for this and we're going to change everyone's way of working, that's bound to produce, resistance in the field, isn't it? And it's perfectly understandable, especially as you've got very senior psychotherapists who know that many people get better with their treatment. So I don't think that's the way to go. I tend to think, if you want to really change something, give me your children.
So the initial phase of your deployment has been included vastly, it's been based vastly outside of the big centers.
Not necessarily outside the big centers. So one of the things that's really critical when you start these new services is that they're not entirely run by people who are going through training. So one of our requirements when we started them was to say that if we're going to give you some extra money to develop one of these services, you, the main hospital or the health trust, need to contribute about 30% of the workforce yourself as experienced, fully trained therapists. And then we will give you the money to have the trainees coming in. That was really critical, I think, because it means that the services can then start in a fully functioning way, because trainees can't treat the most complex cases, but the public wants the service to not be too selective. So if you have the more experienced therapists there, they can see the more complex cases initially. They can also, lead from the front, because the trainees can see some of the work of the more senior therapists. So that was really critical. I think the other thing that we did, as you were asking, what other things were important, when you get extra money for big initiatives like this, it's often the case, and I know this has been the case in Quebec, I know it's been the case in Canada, that the politicians will say, well, there's some area which really needs help. It's very deprived. We know there's a lot of mental health problems there, that sort of thing. So the investment has to go there first. We argued very strongly against that. We said, what we need to show is that we can get good results with these new services. So we should actually implement them. The criteria for deciding where you implement it first should be which area is most ready to do the work, which is the one which has people who really want to work in this system, which is the one that has managers who are willing to support that. And just give money to those areas to start off with in a competitive system, so people have to bid for it. And that way, the first adopters will show good results, and that persuades other people they want to do it. And you might then find that some of the most needy places get their service in the second wave or the third wave. But the advantage of that is we've now learned how to do it really well, so the more serious needs of some of those areas are better addressed. Does that make sense?
Absolutely.
But it was a very critical discussion, I think, with the politicians, because they always think more of, put the money where the biggest need is, whereas we think create the system that works best, and then it'll help everyone.
Thank you. Thank you very much.
Regarding the barriers to access to psychotherapy at the community level,
yes.
Unfortunately, it doesn't seem that just it stems from the economic or actually political aspects of it. At least I'm not sure about Europe, but in North America, there is some perceived dichotomy in terms of psychiatrists versus psychologists. And actually, sometimes at some intrusive way, actually, it's a barrier to access to psychotherapy. I was actually reading a book published by American Psychiatric Association. The author was a psychiatrist on suicide, suicide risk assessment. And the author, in some hair-splitting manner, actually unsuccessfully, had avoided or refused to name psychologists in the entire of the kitab, the book. He was just referring to other health practitioners. And he reminded me of the Harry Potter actually stories when you don't name the Dark Lord because, I don't know, for any reason, which was kind of flattering anyway. So again...
That's a good British development, that one.
Maybe less here in Canada or in Ontario, but even in organization that I'm working in, there was a mental health initiative, and that was the same. Actually, they named psychiatrists, they named mental health nurse, but they didn't name psychologists. They said other actually mental health practitioner. Personally, I'm a clinical psychologist. If I have to follow this, they ask me, who are you? I have to suggest I'm another mental health practitioner. So it's reflected on the decisions because the panels and boards where they make the policies, the MDs have the upper hand. That's why insurance companies have, some of them don't have any coverage for psychotherapy, some of them have more for massage than psychotherapy. So it's not just necessarily the politicians. There is something in professions that must be actually changed.
Yeah, but the politicians have control over that in the end. Yes, I mean, these are all good points. We don't have those issues in England, really. And IAPT is a multidisciplinary workforce. We have a few psychiatrists in it. We have a lot of clinical psychologists in it. But they're not the biggest group. Actually, we have a lot of other professionals in it. The psychological well-being practitioners are not clinical psychologists. They're usually psychology graduates who have some extra training. We have mental health nurses who come in and do the training. We have social workers who come in and do the training. Our view is that this needs to be designed as a competence-based service, not a profession-based service. So anyone who has a background in mental health and is interested in learning these skills, we welcome them. And we develop the service that way. And we are creating essentially a new profession by doing that. But it's all competence-based because, you know, the scale of mental health problems is just too big for us to just look at our existing professions and manage it. We can't. I'm a clinical psychologist, but if I argued just to expand clinical psychology training, we wouldn't be anywhere near where we are in IAPT. It has expanded, but that's not been the biggest component.
I think many people here are familiar with the limitations sometimes of using single diagnosis protocol approaches, given that psychological comorbidity is the rule rather than the exception. I was wondering if you could speak to the IAPT's approach to treating individuals with 2 or 3 or 4 diagnoses or problem descriptors.
Yeah, so I think it's a North American thing, a single diagnosis protocol. What we do, of course, in the training is we teach people how to treat all these different problem descriptors. But you know, the vast majority of people are comorbid in the services, so they have more than one problem. So another key bit of the training is helping people first conceptualize the interrelationship between the conditions. So, you know, if someone's depressed and they also have social anxiety disorder, you need to work out what's the relationship between these two things. Is the depression really secondary to the social anxiety? In which case, you know, going ahead and treating the social anxiety is probably a good idea. But is it, you know, two conditions with slightly separate etiologies, in which case you probably need to treat both, and we teach people how to treat both at the same time. I think this may be a bad thing to say, but if you look at the treatment of older people, there's a very interesting difference in the data, at least as how I read it, between the US data particularly and the English data. So you heard I was saying that we get our very best results with older people, 65% recovery, over 80% reliable improvement. But in many US samples, the outcomes are less good with older people in psychological therapies. And I suspect that's because when you look at the manuals tend to be written for a clinical trial. So it says it's session 3, you do this, it's session 5, you do that, session 7, you do that. And that sort of rather rigid way of delivering treatment, I think, drives older people crazy But the English model is much more to do with let's work out a good formulation of the interrelationship of all of these things, and then we'll pull the different interventions from these protocols and deploy them flexibly. And I think that just works better.
That's amazing. Thank you.
Okay.
I enjoy very much your provocative talk. I'm a clinical psychologist from Venezuela.
Oh, great.
From the Department of Psychiatry, where I teach psychiatrists and clinical psychologists behavioral and cognitive therapies. But now I'm relocated in New York City, and recently they had an important discussion at the Mount Sinai Department of Psychiatry, which is very, very much oriented psychoanalytically.
Yes.
And so they had a speaker who definitely had all kinds of arguments against manualized CBT, and not to talk about, I really think the future of psychotherapy lies in your provocative presentation, but it's very hard to, it's a large population that does not, I mean, of colleagues who think that if you don't have the face-to-face talk or you don't, so it's a difficult argument. And the discussion was that evidence-based psychotherapy is not such. And the discussion even of the title of evidence psychotherapy was like a no-no. That's one question. And the other one is about the economics. How did you manage to have politicians? I don't know, but how do you manage to get close to people that work in economy? Because that's a difficult challenge, I'm sure.
Yes. So on the issue of evidence-based psychotherapy, isn't that? I mean, everyone is entitled to their point of view, but in science it's important to collect the data. So if someone is taking a different approach, what's really important is that they step up to the plate and collect data on what they do, and those things can be compared. And I think one of the things that IAPT has done has shown that it isn't just CBT. There are a range of therapies that are getting good results. And we're finding, in fact, we have Peter Fonagy wrote the manual for the way we do psychodynamic treatment of depression in IAPT. And in the process of doing that and working with Peter, we've really refined the way that's done and made it work very well. But of course, Peter is a very empirical person. He's very happy for the IAPT services to collect outcome data on everyone there, and we can just see how things go. I think what's a problem is if these conversations are not informed by data, and then it's very much just personal feelings. And my experience in life is that feelings can be misleading.
Hi, thank you for your engaging talk. You spoke to 3 different groups in your clinical outcomes. Included people who recovered, people who improved, and then people who reliably deteriorated.
Yes.
And I was wondering if you measured and observed any statistically significant variables that differentiated these groups. You spoke to some things like that might be systematic, like wait times or a number of sessions, or I was wondering if there were client factors that were observed to be different.
Yeah, so the data I was showing on the analyses are aggregate data. So it's basically the publicly available data. So what happens in IAPT is that each service has an IT system which automatically exports individual patient data once a month to the government central processing house. It's anonymized, but so the government has, it's about 7 million patients, treatment courses now, at an individual level. But that's not available at the moment to researchers. We're working to try and make it available, and we will try and make it available in an open access way eventually, but there's lots of issues to how to do that. So the data that people can look at the moment is the sort of average outcomes of different services. So that doesn't really help you very much with these patient characteristics where you need the individual level data, I'm afraid. But we have looked, at least at those factors, at can we predict reliable deterioration? It's a problem because you saw that the overall value is 6%, so there's a bit of a floor effect there. So statistically, it's not a good, a promising measure. But for what it's worth, when I was doing this analysis for today of the change across time, there's an extra variable that we've been measuring about weights, which we hadn't measured until recently. And that's because whenever you make some sort of target for people to reach. There will be some people who try and fake the target. There'll be some people who try and get it technically without necessarily changing things. And it did come to our attention that there seemed to be a few services that patients had mentioned. The service seems to be meeting the waiting list target for how long you wait, But actually what was happening was they were having a long gap between the first and second session, which is gaming the system, isn't it? So we asked the National Processing Centre to publish a report for every area of the gap between the first and second session, as well as the referral to the first one. And so I have looked at that, and in general, how long you wait up to your second session doesn't change the probability very much of whether or not you're going to recover. It just seems to be an incremental thing. But it does actually change your reliable deterioration rate. So those services, and there are very few of them, but those that are doing this with seeing people quite quickly for a first session and then getting them to wait quite a long time before you really get going on therapy, they have a higher reliable deterioration rate. So we're very pleased that we got this extra report, and obviously we're about to work on this issue.
Okay, we're just about out of time for questions, but I think we do want to take the last two and then we'll break for lunch.
Professor, thank you for that excellent discussion. Others have tried to replicate your model, and you made mention of the Norwegians and the Israelis. And as you know, here in Ontario, there's keen interest in IAPT, and some people in this room are actually advising that effort.
Yes,
have you?
Which is really great.
What would be some advice you might give these advisors?
Get the data. That is the most important thing of all, because you can't really learn how to evolve the service, and there will always be learning when you're starting a new thing, unless you get data on everyone. And I think it is the case, Paul Kurdiak would no doubt talk about this more, that at the moment there's a lot of missing data. And there are certain things that you need to do, I think, in order to make sure you get the data. The first is you really need to put a strong emphasis on it in all the services and from the leadership downwards. You also need to help the clinicians to be able to do it. So you need to give them an IT system that supports that. You need to allow them to be able to use the data session by session by looking at the graphs and things, but you also need to include in your training in how to use the measures to influence what you do in a session. So it's not just on the PHQ or the GAD or the impact of event scale seeing what the total score is. It's looking at individual items and saying, does that change what I do? So in PTSD, the impact of event scale is what we use. And if the score's gone down, from last week, we train our therapists to look at, well, why has it gone down? Have the intrusions gone down in frequency because the person's really processing the trauma more and they're also avoiding less? Good outcome. Or has it gone down in frequency because actually the patient is avoiding more? In which case that's a bad outcome, and what you're going to focus on in the next therapy session is dealing with that avoidance. So it's teaching people how to use these measures in a creative, clinical way, which is also a good thing. And then the other thing is to create an outcome monitoring system which removes all possible incentive to having missing data. So quick explanation of that. So we have multiple measures, but the one that politicians like is recovery rates. And early on, we had a crucial decision to make about how we calculate it. Do we say we'll calculate the recovery rate based on everyone who's got measures at the beginning and end of treatment? And I said no. The alternative is to say we calculate on everyone we've treated. So if you haven't got a measure on someone, they're still in the denominator. And that's what we did. And this is really critical. So it means that if you treat 100 people and you get data on 70 of them and 35 of them recover, your nationally reported recovery rate is 35%, not 50%. That, of course, means you're assuming that if you don't demonstrate recovery, you can't claim it. So our measures are called demonstrated recovery. That had an enormous impact. So within 9 months, our services got to over 90% data completeness, because everyone knew there's no point in not getting the data. But if you create an outcome monitoring system, and our children and young people's one did initially, which is the denominator is what you capture, then of course, if you only get data on 24% of your population, and but 12 or 24 out of your 100 and 12 recover, you say that's great, we've got 50% recovery. And so there's no incentive to get extra data. In fact, you'd be worried if I get a bit more data, it'll maybe plunge down. So you have to start like that. So these metrics are incredibly important for changing people's behavior, and you have to get them right.
Thank you for a very eloquent talk and for the analysis. It seems very critical. I had questions about the training aspect of the therapists. How long did it take? Were they paid? Did you actually have more therapists that were delivering the service, or did you actually have the same therapists that now had better tools?
So a bit of both. Okay. So the experienced therapists that came in we often would give them some top-up training because they were going to supervise some of the new trainees, and we didn't want them to be in a situation where the trainees were learning some techniques which the experienced people didn't know. So we created master classes just for the experienced senior therapists. You couldn't get into it if you were a trainee, but it familiarized everyone with the latest techniques. Mm-hmm. But I think the largest bit of the workforce was new therapists. So we were bringing in new people as well, just because we just don't have enough therapists. So we had to do both. But they have different needs, of course, and so we had to organize the training to meet both sets of needs. I think when you're bringing in senior people, but it's a new initiative, you really have to look after their needs as well, because if you don't, they won't necessarily support the new program enough. So that's why we felt they needed a bit of upskilling, but in a very distinguished masterclass type of way as well.
And would that be 12 weeks? Would it be a year?
Yeah, so for the new trainees, if you're becoming a high-intensity therapist, you'd be someone who's already got a mental health profession. So you might be a clinical psychologist, you might be a mental health nurse, but then when you come on the training course, we ask you to resign from your current job, and you get a new job as an IAPT therapist, and you get a full salary, and as you go through the training, when you've completed the training, you keep that as a permanent job. So it's a whole new initiative. And then the way we do the training is it's a 1-year training, and 2 days a week you're in a university setting getting workshops and expert supervision and things, and then 3 days a week you're treating in the service patients with exactly the problems that you're being trained to treat. Because in the past we've had training initiatives where people have gone off for training somewhere else in a new technique, and then they've come back to their own service and there's hardly any patients with the problem that they've been trained to treat. So we put the whole thing together and we say, this is the population you're being trained to treat, so we'll organize your life so this is what you see all the time. Does that make sense?
Yeah, it does. Thank you.